Now starting.
Hi, everyone. Thanks for joining. I know people are still signing on. Thanks for joining us today to hear about kangaroo care and swaddle bathing. I'm going to turn it over to Carol Giggy, who's the Regional Outreach Nurse Educator at Eastern Maine Medical Center. Carol, you take over?
I sure will. Thank you, Kelly. Thank everyone for coming for our webinar today. Today we're going to present on kangaroo care and swaddle bathing. We have been approved for one contact hour, so you'll be receiving that when we are finished. That'll be sent through your email. A disclaimer statement is that no one has any interest in any or benefits from anything from this PowerPoint presentation. We have 5 presenters today that will be presenting on the topic of kangaroo care and swaddle bathing. So we're going to discuss the history of kangaroo care. We're going to also talk about the physiology of kangaroo care. We'll discuss kangaroo care when it's applied for the vaginal delivery in the OR, the postpartum period, and beyond. We'll relate kangaroo care with breastfeeding, and also we'll do the swaddle bathing. So everybody, what is this kangaroo care thing? Everybody wants to know. It seems to be the hot topic. So this is a method of holding our baby skin to skin, chest to chest. The baby is naked except for the diaper, and they're right up against the mother's chest. They just have a little blanket covering their back. The baby is in an upright position against the parent's chest. The baby is kind of like, they call it kangaroo care because it's like when the little Joey is inside the kangaroo pouch and how they snuggle up into their parent that way. It's kind of the same concept with the baby snuggled under the blanket. And so when the baby is in this actual position, the newborn's natural reflexes and their instincts are expressed. If it's not in the proper KC position, meaning it's just not skin to skin, the activation of those neuronal processes initiating and fostering breastfeeding are actually delayed. For the history of kangaroo care originally originated in Bogota, Colombia, back in 1978. There were 2 doctors, Dr. Ray and Dr. Martinez, that thought this would help reduce their preemie mortality in Colombia because a lot of these hospitals didn't have heat, they didn't have formula supplies, very limited sterilization capabilities within their hospitals. Their mortality rate was 70% due to infection, respiratory problems, and simply due to the lack of attention. So they really are the founding fathers of kangaroo care. It was first studied in the United States in the early 1970s, again with preterm infants by Klaus and Kennel, and they described it when they studied it as the early maternal bonding. Dr. Ludington, who is a founding member of kangaroo care here, started studying this in 1996 is when she brought it into the United States. She actually did a lot of work in Bogota, Colombia with kangaroo care, so she was able to bring it here and she knew about it. She is a member of the International Network for Kangaroo Care. We have the International Kangaroo Care Awareness Day, which is May 15th every year, which is a nice day to be able to celebrate that. Joggin put out a practice brief number 5, and it's talking about immediate and sustained skin-to-skin contact for the healthy term newborn after birth. It's recommended for all deliveries. They would like kangaroo care until the first breastfeeding is complete. Of course, we're going to talk about safety because that's a big concern when you're talking about kangaroo care, so we'll discuss safety associated with kangaroo care. Some overall benefits to kangaroo care are a decreased risk for neonatal sepsis, hypothermia, hypoglycemia, and hospital readmissions. It's increased the exclusive breastfeeding rate for hospitals. It provides a decreased pain sensation for the newborns. It's improved sleep for the newborns, decreased stress. They're more alert, and an actual decreased crying of newborns. It reduces the apnea within newborns by 75% when they're in KC. And it's been identified as the first strategy to increase breastfeeding, and this was identified in 2013 by the United States Breastfeeding Committee. So I'm going to turn it over now to Amanda Henderson, and she'll discuss the physiology.
Hi there, welcome. So understanding what's happening when a baby is held in kangaroo position. So I'll talk about the physiology, what is actually happening. And with all mammals, the maternal environment provides protection and promotes optimal growth and development. And you can see here in these photographs various mammals in contact with their mom, and they look pretty safe to me. We see the newborn chest to chest, skin to skin. This is a prone position. We don't have a full body image, but and we hope that the baby's body is flexed, but we can see that the baby's head is to the side. So what happens when these babies are with their moms? Klaus and Kennel worked together and studied, as Carol mentioned, but it was Marshall Klaus in '98 who started identifying what was actually happening when babies did go skin to skin with mom. And he defined a 5-part sequence and termed it the breast crawl. Later in 2008, Colson, she wanted to see what happened when babies were positioned skin to skin, chest to chest, when moms were reclined, and further, examine what was happening. And what she observed was that these babies elicited these primitive neonatal reflexes that not only, got them to the breast, but helped them attach. And so as Klaus said in one of his videos, he described that by observing these babies and identifying the reflexes and the movements, we made sense out of nonsense. So all of these reflexes that we assessed for and weren't really sure what the purpose was, we could see the purpose of attachment to mom's breast and the assistance with breastfeeding when they were skin to skin. Widstrom further defined all of these processes into 9 instinctive stages. So we can actually break this process down over that first hour when babies are skin to skin and see how those reflexes and those movements work to foster breastfeeding and form those attachment behaviors. And this all happens because we have a newborn that is neurologically intact. A newborn that has 5 senses that respond to the touch of mom's skin. So through vision, hearing, taste, touch, and smell, this baby reacts to their environment. Their sense of smell is their strongest at birth, and one of the major senses that they identify immediately following delivery and skin to skin with mom is that substance which is secreted by the Montgomery tubercles on the mom's areola. And that substance not only cleanses that area, but it also smells like amniotic fluid. So this is a very familiar smell and partially what motivates the baby to move and respond to mom's environment. The olfactory sense is linked with the limbic lobe of the brain, and this is the center of the brain that supports our memory, our emotions, and our instinctual behavior responses. So if you think about perhaps smelling chocolate chip cookies, cooking in the oven, that may bring back memories of visiting grandma, or the scent of smoke is alarming, and we respond to that almost instinctually. Just like the baby, when they smell amniotic fluid, they think, I'm home. So the amygdala is a part of the limbic lobe of the brain, and what it does is it processes basic emotions, it regulates social behavior, and what we now know is that oxytocin actually exerts its effects directly on the amygdala. And the amygdala is our center that reduces fear and anxiety, and it also mediates pro-social behavior. What we don't often think about when we think of oxytocin is that it also acts as a neurotransmitter. And so what you see here in this image, you can see oxytocin being sent out into the bloodstream where it exerts its effects on the uterus and on the letdown reflex in mom's breast. But what we don't often think about is how it works as a neurotransmitter and is secreted by these neurosecretory cells. And the hypothalamus is actually quite close to the amygdala. So it easily accesses that center. So how do we get oxytocin flowing? Well, the most obvious things that we think about in maternal-child health is the stimulation of the breast to elicit that milk ejection reflex, uterine pressure as we massage the fundus and cause it to contract, orgasm or arousal states, just loving thoughts alone. So a mom who thinks about her baby crying will release milk. Taking in food. These are things we don't often think about. Stimulating oxytocin is when we take in food and we feel good and relaxed. Light massage and stroking, warmth, and anterior chest and abdominal pressure. The effects of oxytocin are the calm and connection that we experience when we are skin to skin with the baby. It directly counters the effects of cortisol, reduces fear and anxiety, promotes relaxation, stabilizes all vital signs, promotes glucose stabilization, improves nutrient storage, vasodilation, enhanced healing, increases social memory and curiosity, increases trust and sociability, and promotes bonding, reduces pain. And if you're interested in learning more about oxytocin, Kirsten Moberg is a lead researcher on what we know about oxytocin today. In addition to just being, skin to skin and thinking loving thoughts and the chest to chest, that tactile stimulation, in addition, we have what's called C-afferent nerves. Those are cutaneous afferent nerves. And those nerves also stimulate oxytocin, and they respond to the stroking, that innate stroking that moms and babies do when they are together, and the baby elicits those primitive neonatal reflexes. So the baby then strokes mom, and the mom strokes the baby, and again, stimulating oxytocin to promote that calm and connected social. So together they are stable, warm, relaxed, they are healing, they're nourished, they're comfortable, they're curious about one another, and we promote an enhanced infant state regulation. So skin to skin and kangaroo care are the foundation of neuroprotective care.
Hi, I'm Michelle. I work in labor and delivery here at Northern Light EMMC. I was very excited to come back from our conference in June and bring this phenomenon to our labor and delivery unit and all of our moms. We strive every day with every delivery that we possibly can to initiate kangaroo care and get all of our babies started off the same. We just use the term golden hour to describe the first 1 to 2 hours after vaginal delivery or C-section, as Jen Wickett will discuss soon. Casey has
definitely got some proven and dramatic effects on both full-term and premature babies. I did it. Safety is very important to us, obviously, as it is at every facility, I'm sure. So I'll talk to you today about some of the things that we go over with our patients when we provide education to them on admission. All mothers and infants must receive active and ongoing education and assessment for 1 to 2 hours after delivery, with families present as well for reinforcement. Some of the features that we discuss with patients is that you always want to make sure that the infant's face is turned to a side so that you can visualize their nares and make sure that they are effectively breathing. We provide ongoing assessment of the color, tone, and respiratory status throughout those couple of hours. We provide education to the moms, the dads, and any support people that are present on just making sure that that baby does stay safe, that they're not distracted by cell phones or televisions, as we tend to see frequently these days. If the patient's tired and alone, we encourage that the babies go back in the cribs close by the mom's bed so that they can visualize the baby's face, or so that there are no color changes or changes in respiratory status. The baby should always be securely tucked in with a wrapper blanket around the mom and around the back to prevent the baby from slipping or falling. So here in the labor room, we start off every admission with a thorough education on kangaroo care unless a patient arrives in active labor. I always tend to prep my patients by having them put their gown on and remove their bra. That way there's no barrier between the baby and mom at delivery. I always have my patients unbutton their gowns on the shoulders before delivery so that it's easy just to flip it down, place the baby on her chest, and then pull the gown up and wrap a blanket around. We tuck the baby's hat and diaper under her pillow or in our pocket just so we can quickly grab it after delivery, put it on after the cord's been cut, and tuck the baby immediately within the first 60 seconds or so of delivery on mom's chest. After the cord is cut, we just make sure that the baby goes between the sternum and the umbilicus, between the two nipples, and we wrap the blanket around nice and tight and leave the baby there for at least an hour or so uninterrupted. We educate family that grandparents, aunts and uncles can wait to hold that baby until mom's had her appropriate bonding time, and then dad is second. We have a second nurse at the bedside. She or he fills out the baby bands, and they do the baby's vital signs and stuff right on mom. We also do baby's glucose checks on mom when we can, and any immunizations or newborn nursery assessments are best on mom's chest as well. Let's see if I can flip it. The benefits of kangaroo care, I think that Carol and Amanda both touched on a lot of the highlights, but here in the labor room we tend to focus on the stabilization of heart and respiratory rates, the oxygenation rates. The baby's body temperature is regulated way better on mom's chest. It helps the baby conserve calories. The breasts are able to increase in temperature or decrease per the baby's needs. We do frequent temperature checks while the baby's with us after delivery. Studies show positive effects on brain development and functioning. Infants with effective KC do have increased restful sleep time. There's a more rapid weight gain. Susie Ludington said when babies are warm, they don't need to use their energy to regulate their body temperature. They can use that energy to grow instead. We notice decreased crying. Our babies tend to be soothed faster, we find, in KC now. I've noticed a definite increase in breastfeeding and exclusive breastfeeding rates just on our unit alone. And I've also witnessed breast crawls, which I had never truly believed in the past until I witnessed it myself. We find that skin-to-skin dramatically reduces the susceptibility to allergies, infections, and feeding problems, and healthier babies, healthier moms, earlier hospital discharges. Some of the other important components of kangaroo care is the feeling of bonding and closeness with their babies, with both moms and dads. I tend to see that bonding is initiated so fast after delivery now. These moms have an increased confidence in the ability to care for their babies. This helps promote bonding with dads. The babies find their father's voice familiar, and the skin-to-skin contact with them is calming to them as well. Parents have an increased sense of control. We educate our patients on the increased production of prolactin in breast milk, and we talk to them about the effects of oxytocin, as they touched on as well. In the labor room, I've spoken with providers as well, and we've discussed that there has been a decrease in bleeding, it seems, with that immediate KC. The mother's vitals are stabilized faster. Pain control, I tend to notice that when patients are receiving repairs to their perineum, if they've focused on that baby in KC. Reduced stress, reduced maternal anxiety, decreased depression in the long term. And we liked this photo a lot, so we added it. She made me feel like a mom for the first time. And here is the baby in appropriate KC positioning.
Michelle, it's Kelly Bowden. Sorry, the voice from above here. One question that got chatted in was, when do you do the baby's weight?
Well, despite what some of our providers like, we put it off as long as we have to. We used to do it straight after birth, but now it's several hours. I mean, we don't really have like a guideline of, the nursery doesn't pressure us, thank goodness, but I would say it's several hours out in most cases, including our C-section babies. Does that answer your question?
Yeah, that's great. Thank you.
Yeah, you're welcome.
Click this. Hi, so I'm Jen Wickett. I'm presenting the next part about KC with the C-section, which is kind of a different aspect in our labor and delivery unit. I also was part of the group that went to the Cleveland conference and was very excited to get back and implement these changes in our OR as well, because we have, 1 in 4 women have a C-section, so we have a lot of women who have to have that, and they shouldn't have to miss out on this opportunity as well. So for a scheduled section, this works very nicely because you get a chance to educate the family and the patient concerning the plans for the baby after they're born. A lot of times we have add-on sections or stat sections, and you can talk about it for a couple seconds maybe, but still hopefully follow through with the same plan. But if you educate the family and you talk to them that our baby is going to go in KC after the baby's born, and is going to stay the entire OR stay, is going to stay the entire PACU stay, and also that the support person follows along the entire time, and that hopefully family members don't come into the PACU for at least that first hour. That actually helps with the KC so that the baby doesn't get disturbed. I like to have the dad or the support person be my watchdog for me, and I give them that little job to say, hey, just blame it on me, the nurse. She won't allow them to hold the baby, and the dad kind of protects the baby there in KC with mom. So it's kind of nice. It's a nice little job for them to do. So when you go into the OR too, it's very important, once the mom gets her spinal and she lays down, that you kind of talk to her about how the baby is going to be placed, and that it will be a little awkward. It's going to be kind of weird, but we're going to make, because moms a lot of times are worried that they're going to drop their baby, but we're going to reassure that mom that we're going to place the baby just right. It's also really good if you can talk to your anesthesiologist prior and say, hey, the baby's going to be up there, it's going to stay the entire time. We'll make sure someone will be checking on the baby. And even though we've been doing this quite a few months now, it is good to just in the beginning, we talk to our OB providers because sometimes when you're placing the baby, you do hit them in the elbow or something, and you know, you just want to reassure them that you're not going to bother their abdominal area. So it's good to try to talk to them ahead of time. But once you start implementing this and you're doing it regularly, you know, those talks become less and less. We do have a drape now in our C-section packs that has a clear drape option, which is really great. There's a blue part, of course, that still obstructs the view because, you know, we can't have them watching the entire surgery. But when the doctor says it's okay, we drop the blue part. There's a clear drape, and the mom can look up, and the dad can look, and they can actually watch the baby be born, which is kind of nice. At the sterile field, when the baby is born, we do 60 seconds minimum of a delayed cord clamping on every one of our babies if it's, everything looks good. And after that, at this current time, we do still go to the warmer with our babies. I foresee in the future that changing, and hopefully we can go right from the sterile field to the mom. But for now, we do go to the warmer. And there's a couple different ways you can do it here. And a lot of times you can talk to your patient about what they want, because a lot of times the moms really want that weight, or the dad really wants that weight. So if you do talk to your patient prior and they really do want it, what my practice is, I go to the warmer, I do everything in less than 5 minutes if I can. You know, everything's clamped. I let the dad come over and do his little cut because they can't, you know, they can't go to the sterile field and cut the cord. So I let them do that at the warmer. I quickly put their bands on. I do their weight and length really quickly because my goal is when I do put that baby in KC, that baby is going to stay there. And I'm not going to disturb that baby for the rest of the OR stay, the rest of the PACU stay. That baby is going to stay. But it can be, you can skip that, and you can go right to the mom and do it later, maybe when the mom's in the PACU. And placing your baby in KC is a little bit different in a C-section. You can't put the legs down like they should be because you've got the abdominal area where they're doing surgery down there. So I kind of call it a modified KC. And so the baby's kind of, their chest is down on mom, so tummy down and chest down to mom. But their legs are kind of under one side, and their head is on the other breast, looking to the side, of course. And then the OR bed, you can prop her head up so that she can see the mom very nice, so the mom can see the baby. And one thing that when I wrote up this we hadn't been doing, but we have also implemented the bear hugger in the OR, which is a heated blanket that goes over the mom, and we all got in service on that. We are now putting that on our moms, and it is safe to tuck the baby right underneath the bear hugger, and it keeps them both nice and toasty. So, so when the surgery is over, we do have to pull all those drapes down. We have to get mom cleaned up. I instruct the mom to continue holding and focusing on the baby. And the support person is instructed to help, you know, just monitor the baby. Sometimes they have a little vernix or they're a little wet and they kind of slide a little bit. So we just have the support person help. And while we're cleaning mom up, we do have to express her uterus. We also have a device on our OR bed. It's called a hover mat, like a big air mattress. So we don't have to turn our moms to get something underneath them, which is sometimes can be a little dangerous if you're worried about the baby. So this just fluffs right up, and we just slide the mom over nice and smooth. We deflate it, and the baby can stay right with mom during that time. Once we do get her on the wider bed, we can turn her slightly to her side to take that hover mat out. So then you can raise the head of the bed with anesthesia's permission, and you can fix the baby and put the baby in true KC with the legs down, head to the side, chest to chest with mom. And that baby travels right from the OR right to the PACU with mom, and everything can be done in there. We do all our vitals. I've called newborn nursery if the baby needs a sugar. They come over with the scanner. We do all of that right there. And I've even had moms breastfeeding in the OR when the baby's in KC because the baby starts rooting around and looking. And of course you do have to offer assistance in that situation because she is kind of in an awkward position. Sometimes you help hold the baby's head up a little bit while she breastfeeds. So that's really great. And I know we've touched on this already, the benefits of KC, but everything stabilizes for the baby, including the temperature and the blood sugar. They're less stressed. And I've even had moms and dads and support people say to me, why isn't the baby crying anymore? And I'm like, well, this baby's really, really happy where this baby is. And it promotes bonding. I've found women a lot of times are scared out of their minds to go into an OR and have this major surgery, and they're very scared. And the second we put that baby in KC, they calm down. They don't even know they're having surgery anymore. They're focusing on their baby. They're happy. I've even had patients say, I don't understand it. I feel so happy. I feel so relaxed. I'm not worried anymore. They tend to not even know, maybe they had some discomfort and they're not having it anymore. So that's a wonderful thing. But of course, there's always barriers, and we've had our fair share of them. And sometimes you have anesthesia, everybody's a little different, and some of them are not supportive of having the baby up there, especially if anything starts to go wrong with mom, if her vital signs change, or if they think the baby doesn't look good. So that just requires you to have good communication with them and let them know that you're there and you're helping monitor the baby. And of course, in any sort of situation that's not okay, we would take the baby and let them focus on mom if something wasn't okay. Some of our OB docs weren't comfortable with us positioning the baby. I would get comments, hey, what are you doing down there out there, and different things. And as long as, again, proper communication, and a lot of times when I know that I have a doctor who's not terribly comfortable with it, and I'm placing a baby, I always say, hey, is that okay, Dr. So-and-so? Do you feel this is all right? Is that, the baby's butt's not too close to you? Is everything good? So good communication. Another thing I saw a lot was some of the nurses wouldn't position the baby properly. So, for instance, if the baby's head was sliding up towards the mom's neck, or if the baby wasn't in a good position, then the moms were like, this isn't comfortable for me. I don't want the baby. Can someone take the baby away? And so it's necessary that we put these babies in a good position so that the moms will want to keep them there and not want the baby taken away. And then, of course, in the past, we always had this process of checking the baby into the nursery to get vitals and get meds and all that stuff. And there's some nurses that are holding on to that, but I really don't see that much anymore here. I think we've made huge strides, and that doesn't really happen here anymore. And then, of course, it is a change in practice for nurses. Normally we would have that baby in a crib. We could do all our vitals and everything, but now we have to go over and kind of mess with the baby while they're in KC, and some nurses were uncomfortable with that. But again, I've seen as we do this more and more, people become more and more comfortable with it. And then, of course, you have the support person who when am I going to hold the baby? When is grandma going to hold the baby? People need to hold the baby. And again, I think if you educate them prior and talk to them about the importance and the benefits, I've really never had many patients say, well, I don't care about that. Grandma needs to hold the baby. They're usually very supportive when they hear about the wonderful things that KC offers. And then, of course, you always have two nurses in the OR. One is a circulating nurse who is documenting and counting, and then one is the baby nurse. And sometimes she steps out. So sometimes the circulating nurse isn't comfortable with that, but we've made great strides in that where there's good communication between the circulating nurse and anesthesia with that baby there, and it's working really well. Which I think I talked about all this already. So communication and education prior is going to help. And then I just wanted to end with, I started working here in 2004. I actually had sections for my babies as well, and one of my babies was born here in 2005. So I know it from a nursing standpoint and a patient. And with my section, there was a breech baby. There was nothing wrong. The baby was taken to the warmer. Nurse wrapped the baby up in a blanket, brought the baby to me. She held the baby and let me give the baby a kiss. 5 minutes later, baby goes to newborn nursery. Baby was not allowed back in the OR and was not allowed back in the PACU. And I didn't see my baby until 3 hours later when I got back to my postpartum room. And there was nothing wrong with either of us. We were fine. And today, our babies go to the warmer for 5 minutes or less in a C-section, and they're placed in KC, and they do not leave this patient until something is unfortunately wrong or the patient requests it. And that is huge. We've come a long way. And then this is a picture of a poster that we did to show everyone how we've come and how far we are to support KC and how we're doing it in the ORs and the PACU.
Thank you. Hi, I'm Tricia Collins. I'm the charge nurse in the postpartum unit, and so I'll speak to welcoming our mother-baby dyad over there. They do such a great job in the labor and delivery area that it's just a continuum of care for us. But really focusing on that dyad, encouraging it, and beyond is what's going to help your breastfeeding rates and even when the mom goes home. So just encouraging that and being their cheerleader to staff and to patients, because, in any postpartum unit, we always have those people that are like, no, I don't have time for that. So just really encouraging it, and once they see it, they're hooked. It really does work. So in welcoming the mother-baby dyad to postpartum, ask them if they did KC or skin-to-skin. Do they know what it is? And most of the time, especially in our unit, they've seen it. Ask if it was explained to them, reinforce or inform the mother, partner, and family about it, and the benefits for all who practice. In our area, it's not just moms that are doing it. I was getting a mom up for the first time, and I said, how are your legs? She had that epidural shuffle going on. And she goes, I think I can feel it better. And I said, well, is it okay if you hand the baby off to dad? Baby was in KC. And she goes, absolutely. And she goes to get up with the baby, and she goes, honey, KC. And he goes, oh, I'm so sorry. He whips his shirt off and, puts the baby skin to skin, puts a blanket over him. Like, he was on it too. So obviously, it wasn't just my teaching. They had heard it, and just that reinforcement of your teaching. Okay, letting them know what to expect, how long, and we say as long as frequently possible. It can be continued at home, ideally for the first 3 months. It should continue throughout postpartum because it also helps the baby and mother sleep, recommended by the American Academy of Pediatrics. It can be done by anyone designated by parents. We've seen, we had great pictures shown to us when we went to the class of siblings doing KC with NICU babies. So it can be safely done as long as it's monitored, and I'll speak to that a little bit later. Okay, testing and procedures needing to be done on myself for a baby. Parents are always wondering about that. Our old model was, okay, it's midnight, we're going to take the baby to the nursery, we'll see you in an hour. Many times we're doing those procedures right in the room with the baby in KC. Definitely blood sugars, eyes and thighs, all that stuff. And then hepatitis B can be done with baby in KC. The only limitation we have here at Eastern Maine is we only have one hearing screen. And we found that if we traveled it from place to place, it needed to be calibrated more frequently, and we had troubles with it. So when we do need to do a hearing screen, obviously we need to take the baby to the nursery for that. So definitely encouraging KC, and for the baby to room in the mother's room. And it's a huge change in practice for us. You have to realize that our nursery was used as a boarding spot at night. I'm the charge nurse at night, so we saw that. We didn't do delayed bathing. Now it's just something we automatically do. The baby's not bathed for 6 hours. And so, a lot of us have been here a long time, and we thought, this is never going to happen. And here we are already. Do we have a long way to go still? We do, but we've made great strides towards this. These are all the benefits. I think Michelle and Amanda spoke to them well. Making sure, though, for safety, that someone should watch you at all times. Because of this oxytocin, you can feel sleepy, and so we don't want that face imprinted in breast tissue, okay? If you're tired and alone, put the infant on its back in its own bed. Don't put your baby in your bed for sleep. We really discourage that for safety reasons. We talked about the safe positioning guidelines, so I won't go into that. And this is a RAST assessment for KC and skin-to-skin. So this is a chart that you do, and you would fill it out. It's done more frequently in recovery
and labor room, and then we're still doing it every time we're in the room to talk to mom. We're doing this RAST assessment, okay? We're speaking to respirations, activity, position, perfusion, and tone, okay? A score of 0 to 1 in any field requires an intervention to reduce the risk of sudden unexplained postnatal collapse of a newborn, and Carol talked about that earlier. A score less than 2 in the physician field requires immediate intervention, okay? We're repositioning, we're educating, doing all that stuff. In 2 or more fields in the respiratory activity, perfusion, and tone categories, our score is 0. Casey needs to be stopped, okay? Document any interventions, so documentation is going to become a piece of this for you. The lower the RAP score, the higher the risk of SUPC. Score of 10 is minimal risk, and it's minimal only because the infant's condition and position, especially position, can change swiftly. So it's just all about being present. I always say must be present to win. So especially in that immediate postpartum period, that nurse is there, okay? And then whenever you go into the room, even if the lights are dim, you still need to assess that mother and make sure that she's safe. Because Casey is encouraged in the postnatal ward to facilitate breastfeeding, it should be considered whenever you're in the room, no matter where the infant is found, in the crib, swaddled in someone's arms, snuggled up to chest or in Casey. 1/3 of SUPCs occur in the first 24 to 48 hours of life. So nursing responsibilities for Casey, skin to skin, success for inpatients and beyond is being an advocate and an educator. Okay, frequent encouragement of how well they're doing. Encourage partners. Oh my God, you're doing so good. Breastfeeding, how's breastfeeding going? Look at the pees and poops. Oh my gosh, the baby's Billy's good. All this stuff will help mom. I had a mom that had a baby in the NICU. She didn't get to breastfeed as much. She never did skin to skin. Baby had Billy issues. She had bonding issues. She had milk production issues. Her baby came. She still had a C-section. Baby was growing. Mom ended up having some blood pressure problems, was worried about baby bonding because she had to go back to the labor room on MAG. I said, we're still going to do skin to skin. You're still going to get to breastfeed, all this stuff. Mom went home, breastfeeding success. She was a great example, and I kept saying, you are a breastfeeding rock star. You're a skin to skin rock star. And she was like, this is such a different experience from last time. She was so encouraged. Her milk was in by the time she went to labor room to get MAG for her blood pressures. Regardless of whether she's breastfeeding, it should still be encouraged because of all the benefits, okay? Showing how baby is responding. You look at the feeding cues. Breast crawl is a great one. Temperature control, less crying, and I say less crying for mom and baby because everybody's happier, okay? Frequent rounding and documentation, those are our safety features. Be willing to be flexible with vitals, testing, meds, and assessments. I can assess my mom right when she's doing KC. And I always say, do you want to have hepatitis B if it hasn't been administered yet? And they're like, oh, but I really want to do KC. I'm like, I can do it while the baby's in KC, like no problem. You need to be flexible. And I'm an old dog, and you can teach me a new trick. So these young birds coming down the pike, if all they ever know is KC and skin to skin, you're not having to teach anything new. It's just the norm, okay? Let KC and skin to skin and subsequent breastfeeding happen. As nurses, we want to help. However, spontaneous latch with KC provides secure, leak-free, pain-free latch. Don't rush it. When I was first teaching people how to breastfeed, I wanted to hold that head. I wanted to grab mom's breast. I wanted to do everything for her. And I took her really out of the equation. Skin to skin, breast crawl, that makes that dyad totally part of the equation. Education regarding benefits and the baby, to mother and baby, skin to skin are just going to help cement what they've already heard either in childbirth class, over in labor room, and beyond, okay? And discussing safe KC at home with grandparents, siblings, and other people parents designate. Reducing distractions, that includes cell phones, TV, social media, visitors, alcohol, substance abuse, smoking. When we went to the class, they talked about a baby that had died from SUPC, and it was found that the baby got embedded in breast tissue. Mom had been sent over 136 text messages in the time that the baby had suffered this collapse. She was just holding the baby and texting the whole time and didn't realize that her baby wasn't breathing. Okay. Discourage bed sharing, and that's just vigilance. How many times do we go in and mom has fallen asleep? She's very relaxed. It's going back and saying to her, do you feel too tired? Maybe dad could hold skin to skin, or if she doesn't have a partner, put that baby in the bassinet in its own space, not with mother in bed. Okay. Share your success stories with other staff, patients, and families regarding the benefits of KC. And once you see it and you see the benefits, it's hooked, and you just want to see it more and more. It's really amazing. And I think when we all first went to this training, we were like, yeah, I'm pretty excited. We're going to go. But in the back of our mind, we had our old model, how we used to do things, and we're like, how's that going to work? And it's amazing how you go to this, you see the research, but physically seeing a baby and a mother and a unit respond to this, it's pretty amazing, and it's catchy. So thank you. Oh, this is my grandbaby. I had to, give a props to them. This was a baby born at a baby-friendly hospital by C-section. Mine was in 1990, and I was like Jen Wickett, where I didn't see my baby for 3.5 hours, and then they're like, "Hey, you go breastfeed." I was like, "What?" This baby got eyes and thighs, everything in the OR. Mom was skin to skin when she came to her PACU room, and this baby went right to breastfeeding, regardless of the fact that mom did have a little bit of trouble with breastfeeding, but the first breastfeeding was like, she came into the PACU. We got to visit briefly, and the baby was already on breast. She was like amazed by the success. And of course, he never had blood sugar problems. Obviously, he's a little chunk of munka, so he did great.
Great. So,
Wow.
I'm sorry sorry, it's Kelly. There was one more question about the weighing the baby, not so much with the C-section, but with the vaginal delivery. How do you navigate that conversation in a similar way with the family? Like encourage them to hold off on the baby's weight? Or the other thing that I've run into around the state is sometimes like the computer electronic health record forces you to enter a baby's weight before you can technically admit the baby to the hospital?
So hi, it's Jen Wickett. So for our computer, we don't have to have the weight to initiate the chart for the baby. Is it still, Trish, am I correct in saying concerning blood sugars, do you still need a weight? So the one thing we do need is the weight for the blood sugar. So if so what we do is we hold off to try to get in that first hour KC, because we're not too worried about, unless the baby's symptomatic. But in that first hour, we try to maintain KC and initiate a breastfeed within that hour, if possible, if they're breastfeeding. And then a lot of times, well, especially like in the PACU, if I didn't get in the OR, I do a quick wait when I'm cleaning the mom up in the PACU, when we roll her side to side. And sometimes you can sneak the baby away in the vaginal delivery room and do a quick wait, and it can be less than a couple minutes. And so usually, but that requires a lot of education prior, making sure that we educate the mom and the support person that the weight, you're not going to know the weight, and you don't be asking us to wait, just let them know you'll know like later, after an hour, tell all your family you're not going to know the weight, it's not going to be on Facebook, that kind of thing. Does that answer your question?
Yeah, that's great. Thank you.
All right, so I'm Sarah. I am a lactation consultant here at Eastern Maine, and I also went to the KC conference and thoroughly enjoyed it and came back excited to teach all of our new parents about it. All right, so I'm going to touch on some things that Tricia and Michelle kind of touched on and a little bit more in depth. So as Tricia stated, regardless of feeding choice, we encourage all parents to hold their babies Kangaroo Care as much as possible, as long as possible. In fact, we tell our parents that you cannot overdo KC. Studies show that babies receive benefits of Kangaroo Care up to the age of 16 weeks. So we want these parents to do it here and at home. Studies also show that parents receive benefits from Kangaroo Care as well, and these benefits are reduced stress, reduced anxiety, it increases their feelings of attachment to their baby, it increases their confidence and their ability to care for their baby, and increases their sense of control over what is going on with their child. If that mother is planning on breastfeeding, it also will contribute to an increase in milk supply. And how does that happen? Oh, hold on. I apologize. Oxytocin that we've been talking a lot about. So oxytocin, we all know it's a love hormone, and it's also responsible for the ejection of breast milk. So put that baby in Kangaroo Care, and we get that oxytocin circulating and flowing in both mom and baby. But in mom, it pairs with prolactin, and it helps with the production of breast milk, but more importantly, the release or the ejection of breast milk. So we put that baby right skin to skin, no bra, no tiny little baby shirt, no receiving blanket. There's nothing between that mom and that baby to interfere with that connection and those theophoric nerves that Amanda mentioned before. So sometimes we have babies that are extra sleepy and they like to sleep through feeding times. We tell parents, put that baby right in KC 30 minutes prior to that feeding time, because what we're doing is we're putting that baby right there with unlimited access to their food source. I also tell parents this is called the restaurant, or the place where that baby gets food. And I'll say, so you know when you walk into a restaurant and you smell French fries, and before you went to the restaurant, you didn't want French fries, but now you got to have French fries? It's the same exact thing. Put that baby where they can smell the French fries, right in the restaurant. And again, so that baby can have the access to the food whenever he or she wants it. So studies also show that the moms that routinely hold their babies in Kangaroo Care have more breastfeeding sessions, because those babies are searching and looking for the food. And if that mom is having an increased stimulation, through those feedings, she's going to be telling her body to produce milk sooner, and we have milk coming in faster. And when that happens, we have less weight loss, stabilized blood sugars, and a decrease in our jaundice. Another piece that factors into stabilized glucose levels is thermoregulation, which we touched on earlier as well. But mom's body will heat and cool by 2 degrees within 1 minute to meet the needs of that baby. And if that mom were to have twins, she had one baby on each breast, her breasts would be independent temperatures of each other to meet the needs of that infant residing on them. So this mom is the incubator. She's the perfect incubator environment for these babies. They're warm, they're safe, they are in homeostasis. So when those babies are warm and thermoregulated, their body does not need to burn their stores of brown fat that are in their bodies. Because when that brown fat needs to be used, it requires glucose. So keeping those babies warm, homeostasis, they're free to just transition to this outside world. And that mother has an increase in confidence level in her ability to care for her children. She can meet their needs. So what happens when they're separated? Because that happens. So we encourage our NICU moms to hold their babies as often as they can. If they're able to hold those babies in Kangaroo Care, depending on that infant's stability and situation as to why they're in NICU, we encourage them to hold those babies as often as possible to really get that oxytocin flowing, again, in the baby and in the mom for those stabilizing factors that it provides for that baby, but also for her milk production. If a mom cannot hold her baby in Kangaroo Care, we encourage her to sit near her baby, to look at her baby, to maybe smell things that are around her baby, and if she's able to touch her baby, to touch her baby. Whatever we can do to trigger that oxytocin to start flowing in her body. Because that oxytocin, again, is responsible for the ejection of breast milk. So we tell our moms, pump right after you hold that baby in Kangaroo Care, pump while you're looking at your baby. And you should see an increase in output because of that ejection. So time and time again, we'll share this with moms, and later that day or the next day we'll come back and they are glowing. They have these little vials of breast milk that they pumped, and typically it's double the amount. They are thrilled to report that after following these simple steps, they're producing all this much more milk, and look what they can do. And we just tell them, well, that's oxytocin, And that was all you. You did that for your baby. Way to go, Mom. You're awesome. So now these moms have an increased confidence in their ability to provide for their child as well. So infants that are substance exposed also benefit from Kangaroo Care because of all those physiologically stabilizing factors. Kangaroo Care is sleep-inducing, it's calming. Studies are finding that these infants need less medication when they're held in Kangaroo Care, that they eat better, they gain weight, they need less treatment, and often discharge sooner. So really, in conclusion, no matter our situation, if we have a healthy newborn or a NICU situation, we want all of our moms discharging, our parents discharging, feeling comfortable and confident in their ability to take care of their child when they leave here. And Kangaroo Care does that for them. It gives them that feeling of self-reliance that they can take care of their child. And honestly, it's so much more than a tool that we give them. It's a gift that they can bring home with them. And
hi, this is Amanda again, and I'm going to talk about swaddle bathing as an extension of Kangaroo Care. Unlike the Kangaroo Care that we've been implementing so far, swaddle bathing is a new strategy that we'd like to see implemented just to sort of continue as an extension of Kangaroo Care. That was let me go back. Oh, well, I can't remember what that slide was, but we'll just keep going. So the benefits of swaddle bathing are that the newborn itself it's a calming, more relaxed procedure than a sponge bath, and so we see greater temperature stability, we see less stress and crying, and it also facilitates Kangaroo Care because one of the components is that we get that baby skin to skin with mom following the bath. So therefore, we're likely to see increased breastfeeding, and we know that swaddle bathing also benefits preterm and NICU infants as well. For the parents, it's also less stressful for the parents because they can participate in the bath. And with the baby crying less, they're also less stressed. The bath can be done right in the baby's room, so it encourages rooming in. And there's an opportunity for engaged learning. So as the baby is bathed, the nurse can point out some of those reflexes and responses and physical characteristics to prepare them for going home. So therefore, the parents are also confident as they get ready to leave, and overall, it's part of a satisfying birth experience. So this is a news clip from a hospital out in Colorado. I'm just going to play it, and you can see some of the differences between traditional sponge bathing and swaddle bathing. Maybe. Can anybody hear that on the other side? Kelly?
No, we can't hear the audio, sorry.
Okay. Well, we won't spend too much time trying to do that, but maybe visually you can see the response of the baby without hearing the news report. But you can see that this baby is calm and how this is done. The idea is that you're not doing a lot of rubbing to the baby. Oh, I know what that slide was that didn't show up. Oh. Now it's occurred. So A1 actually has swaddle bathing as the preferred method of infant bathing in their latest edition of neonatal skin care. I'll just talk about that slide while this picture is being shown. And they've actually, I was surprised to know that they've actually recommended swaddle bathing since 2001. Yeah. So this has been in the books for a long time as the preferred infant bathing technique. So we're a little late to the game. All right, I'm going to just go to the next slide here. So, and I think all of these slides seem to be a little mixed up. This looks like one half of my slide here. So in order to prepare for the bath, we want to delay the bath at least 6 hours, but can be delayed as long as 24 hours. We want to make sure that we're telling the parents that the baby does not need to be bathed daily, only 2 to 3 times a week. It's important to make sure you have all your supplies before you begin. And if this is the first bath, we need to remember to use gloves. It should be a neutral thermal environment, so making sure that there's no drafts in the room, that the temperature is 79 to 81 degrees, and that the tub needs to be on a firm, stable surface with the water temperature being less than 104 but 100 or greater. Oh, here's my procedure. So to begin, as you have your supplies, you want to swaddle the infant and then gently immerse the baby into the tub up to the shoulders. So the neck and the head should be above the water, and provide continuous support behind the baby's back. And begin with the face using plain water and cleansing the eyes with a clean cloth from the inside to the outside. The recommendation is to use minimal soap on the rest of the body and unwrapping each body part as you move through the process. And you can use a rinse cup, or I just read about some places are using a peri bottle so you can more accurately direct the spray, especially when you're rinsing the head. So again, you want to point out any unique characteristics or behavior to the parents as hopefully they go through this process with you as the nurse. The other important thing is to limit the bath time. Ideally, it should be between 5 and 7 minutes, but no longer than 10 minutes. And dry with warm blankets, and then encourage the kangaroo care following the bath. And this is one hospital's video. I'm just going to, I know we're not going to be able to hear it, but I want you to see the baby being handled and immersed in the water, because I think it's helpful to see it since we don't have any other video. And this baby is actually in the NICU. You'll see some of the leads. So A1 also does not recommend using a cloth for the whole body. They recommend using the hands to actually massage and wipe down the baby to minimize removal of vernix and all the other goodies that are on the newborn skin. So in this particular video, they did the shampoo first, but other procedures that I read talk about doing the shampoo last. So it all depends, I think, on whoever's doing the bath and what they think is. And so everyone here is just remarking on how calm the baby is. and this particular video, they are using their hands instead of a cloth. The other thing that's important, and you can see how they're holding the arms in that flex position. So that's another important aspect of the swaddle bathing, is keeping the whole body in the flex position as much as possible. And now they're getting ready to transition the baby out of the water. And looks pretty calm. So moving along, because I know we're running short on time. There are many tubs out there. I can tell you that the Turtle Tub has their act together. They've got a lot of great products, and they've got a lot of evidence to support this process, and you can go to their website. They've even got this practice guideline along with a video and a whole list of references. But I want to make sure you know that any tub can be used. These are other examples out there. So benefits for the institution is that we're providing evidence-based care as soon as we can implement this process, and it meets the challenges for the Institute of Medicine to provide evidence-based care, as well as the Joint Commission standards to improve breastfeeding rates and KC practice. Of course, it also promotes all other baby-friendly practices. In a survey by Brogan and Rapkin in 2017, who had implemented this practice, they found that for most parents that were doing the swaddle bathing, it was just for less than half of them, this was their first bath. 3/4 of them desired help with the bath, so it's important that there's staff available to support them with this. 3/4 of them believed that the tub was more comfortable. Most believe it helped prepare them for home, and almost 90% desired the opportunity and thought it was an important part of the birth experience. The challenges may be engaging the parents, so instead of saying it's time to bathe your newborn, instead of saying, would you like to bathe your newborn, because some parents may be reluctant. Of course, staff education is important so that everyone knows how to do this, and appreciating how this is going to work with time management. The cost of the equipment, I have to say this is not correct in terms of the tubs. This is the private cost of tubs. I've learned that for institutions, the cost to say the turtle tub is much higher. The tub liners for multi-patient use to prevent cross-contamination is about $45 for 25 liners. And those are my references. Right, here's Carol.
All right, that ends our webinar on kangaroo care and swaddle bathing. Are there any questions?
I'm just trying to unmute everybody, sorry. I'm unmuting everyone so you can ask your questions verbally. Try to catch the questions that you're typing.
The application against President Trump.
Okay, does anyone have any questions? There's a lot of background noise now.
I think there's three. Really friendly, short
Of your screen on the right-hand side. So let's see. I just want to remind people that the evaluation will be emailed to you. It'll be a Survey Monkey. We'll ask you to complete that in order to get your nursing contact hours. Candy, I've unmuted you, and Yvonne, I've unmuted you. Do either of you have any questions? Okay. Got Patience and Lynn. Do you have any questions?
Oh, hi. I don't think we have any questions. Love with the whole bath thing. So what we need to do is talk our pediatricians into letting us to do tub bath. It's fun.
Yeah, the videos, pictures worth 1,000. So, ask.
We haven't implemented bathing yet, but it's part of our
I muted mine.
immersion bathing. So we haven't had to communicate with the pediatrician yet.
Okay, let's see. Do you have any other questions coming in? I don't see any. Liana, you see Carrie Jean or Karen?
No, I'm good.
Okay, great. Julia?
I think for us, our biggest struggle right now is the doctors would like the babies to stay skin to skin in the OR, and the OR staff is just really uncomfortable with the babies staying skin to skin while mom is being cleaned up after the surgery and moving from the surgical table to the postpartum bed. So we're finding it a struggle there in that aspect.
So what do you guys use to move your patients from the OR bed to the regular bed?
So before they get moved to the bed, they're turned side to side to clean them. The OR crew wants them cleaned front, back, side, completely before they go to PACU. And then they're being moved via a slide board from the OR table onto the bed.
Because I've heard that other hospitals leave the babies there, even with a slide board. We've never done that here. We use our hover mat, but we do clean them up in the OR. We don't do the whole process because our cleanup process happens in the PACU when they're ready to be discharged from the PACU. Is it OR nurses or like who in particular are not comfortable?
The OR nurses are the most uncomfortable.
So are your OR nurses labor and delivery nurses or are they OR nurses?
No, they're OR nurses.
So that's got to come with, like does the labor and delivery nurse stay there with the baby the entire time?
Yes. And we've tried saying that the labor and delivery nurse will stay right there with the baby, hands on the baby the whole time the mother's being turned. Mom has her hands free, so she's able to hold the baby as well, but they're still not comfortable with the baby staying skin to skin during the turning process and the moving process. So what we've been doing is we've been taking the baby off the mom as soon as the cleanup is started, as soon as the patient is ready to be turned side to side, and then the mom gets the baby back as soon as she's moved on to her postpartum bed, but that still leads to an interruption in the uninterrupted skin-to-skin process.
I think that, we've actually encountered, we did have a scrub tech from the OR who really, wanted us to move the baby, wasn't comfortable with the baby there. In this situation, I think education would help if the OR people knew about the benefits. Unfortunately, I think you guys just kind of keep moving forward with it and trying to make them feel comfortable. If somebody stays in there and says, I'm going to hang on to the baby the whole time while you're cleaning her up, whether or not they have to be, management has to get involved because you're right. We don't want to interrupt the skin to skin just because people are not comfortable. That's not really a good reason. If there's something wrong with the baby, something wrong with the mom, of course. But we don't want to interrupt it because someone isn't comfortable with it. So look at ways maybe that you can make them feel comfortable, whether or not it's that labor and delivery nurse that has her hands on the baby the entire time. I'm not going to let go of this baby the entire time that you're cleaning up, and we're going to just focus on the baby. You guys do your thing, and maybe start trying to do that, offer more tips and education, maybe get management involved as far as you got an idea, too?
Yes. What if they got an anesthesiologist or
That's a good idea, too. Yeah, if you get like an anesthesiologist or a doctor who's a champion who talks about it more, or even a nurse, a labor and delivery nurse too, who becomes the champion and goes in and tries to be part of a lot of the C-sections and help them become comfortable. When you make them aware of the benefits and the things it does for mom and baby, and then making them feel comfortable that you're there, you're holding the baby, maybe that could help.
Right. Right. Those are good ideas, and we're certainly trying. It's just been our biggest struggle thus far. I think the hover mat's interesting. We've never used the hover mat. I also think potentially saving that cleanup for when they're in PACU is very interesting, because then we would not be battling that 1 hour time slot so drastically like we are in the OR.
We clean the top of the mom and, of course, the perineum, but we do not turn them side to side in the OR to clean them. We do that in the PACU. Okay. So maybe if you decided to do that instead. And just, we had circulating labor and delivery nurses when we started it who were not comfortable with the newborn attendant leaving with baby skin to skin. And the more and the more and the more we did it, now they're fine with it. Because we've communicated with them, we've talked to them about the benefits, anesthesia's involved. So I think the more you talk about it, the more you are a champion about it, it'll happen.
Yeah.
Just some tips.
Thank you.
Thank you. Is that helpful?
It is. Thank you. I appreciate it. And it's nice to just brainstorm and try to come up with some new things. And, sometimes you start to feel defeated when you've tried and tried and tried and it's not working. So it's nice to hear that, people are having success with it.
We're behind you. Keep going.
Thank you.
Thank you.
So I know that we are over time by 15 minutes, but we still have people on the call. So on the chance that somebody still has a question, Janice Lessard, did you have anything you wanted to ask? Cheryl up in Fort Kent. How are things in Fort Kent? And did you have any questions for the group? All right, I think I've gone through the list of who's still on the call. I want to thank the team at Northern Light Eastern Maine Medical Center for their work and putting on today's webinar. It's great to hear all of the quality improvement projects going on around the state. Again, you'll get an email and follow-up. It'll come from Kathleen Taylor. Please answer that, and then we'll be emailing you your nursing contact hours. Carol, do you need to add anything else?
No, I think I'm good, Kelly. I wanted to thank everyone also for participating, for presenting today.
All right, thanks, everyone. Have a great day.
Thanks. Bye-bye.
That's pretty.
Hello?
Kathy, do you remember how I end the recording?
No, I do not remember that. Is it still going, is what you're saying?
Well, they're just logging out. Everybody else is pretty much signed out. And before I shut down the GoToMeeting, I didn't want to press a button until I knew that we could save the recording.
Well, it was, are you there? It was already on save recording. I know when you keyed on, I looked at that. So,
it just says this is being recorded.
How to end recording on GoToMeeting.
Oh, I just saw end webinar. I'm ending it.
Oh, okay. That seems simple enough, huh?